should have.
Yeah. I was also doing the K-23, so I was helping him with that. He gave me a hard responsibility. He wanted me to write draft letters as if I were Jeremy Palm. And somehow I keep recommending him. I don't know those guys. I don't know what the interaction with them. Just putting in the K-23 is pretty sophisticated stuff. And somehow I had to craft these letters, so that was a challenge.
You're staying busy with us. Thanks
Yeah,
for doing all that.
what's good, I like it.
Yeah, I'll send you a different version.
Europe, I was over the house.
He's gone for 2 weeks, and we had our kids.
I know, he said he's going to miss the birth of your grandchild.
Yeah.
He loves to travel.
Yeah, he did. He said,
You know, I think they would have stayed, but they have like money. So they send a lot of people there. Aren't you going on a trip?
Oh, okay.
well, there's something about a trip to Carl's.
No, my
I don't know, I haven't signed on to that yet. But he gave me wine. Yeah.
I saw him that way.
Yeah.
So I'll send you if it's all right. I can send it my replies, but I'm going to send it off to Matt. So I'll send it.
I feel like 4 guys bring it up. The oldest brother. I had this my phone. I had
I'm pretty sure he's in San Francisco.
this guy says, yeah. Get out there, kind of the trunk. Oh, yeah. Sundays. I read that. He's locked up the truck. Is that copy June 1 in this? Comes out, it's like, we can get approval. Just
What's the? I don't think
Four of us let him check.
because it was until 3 in the afternoon.
She has a bad shoulder, so.
It's from like 3 to 4. That's CLI. So I was assuming that they're
She's
going
got
to do her morning thing and
crap.
go over. I don't mind doing something. It's fine. It actually worked out fine with the car now last week. It was actually a little bit easier, frankly, because you just follow it. Like you have them to yourself. Like there's nowhere else you can be. So.
Yeah, but we'll put this on the screen. Usually it just like 4 months. I'm looking at it.
Yeah, there's a lot of stuff.
Oh, I know.
5
Yeah, I was
years.
thinking about that.
Right, in a row, all day.
So when I do this, my daughter, if she runs it, she can have all my.
Rebooting. Rebooting.
So to earn money. So all right, but you
Every day
do
this week.
you have friends for the other one.
It's just so much the same exact same way.
Yeah. I was just looking at disclose the app and stuff. So I think that's a lot of fun,
Good words. I gotta take a while to do after a run of good luck. No.
Travis is doing
Heartburn.
Travis.
We see it.
I feel like this first 5. You don't have
Great. Sorry, I'm able to see what I'm pointing to right here. So, with regards to asthma risk, which we're looking at right here, the only bacteria that seemed to cause increased risk of asthma at 6 to 7 years of age was C. difficile, and And that seemed to be restricted just to families where there was parental A to B, as you didn't see that same, you did not see that same increased odds ratio when there was in the family history of A to B, but it did seem to make a difference with that particular bacteria being present or not in these infants, in terms of the increased risk of asthma in 6 to 7 years. I want to go on now and just talk about some of those different contributing factors that I discussed in the beginning, and how they all play a role. I'll just touch on a few different studies that have looked at these various factors and how they're contributing to the rise in allergic disease. So increased perennial allergen exposure, we've touched on this already a little bit. And this includes things like dust mite, obviously, but mold and other things where kind of the heating and ventilation systems in homes have made the growth of things like molds and dust mite a lot more easy as time has gone on. In a study in JAC in 2007, this was a study that looked at a bunch of children who were at risk of ATP and looked at the various levels of dust mite they were being exposed to when they were infants. And then they looked at whether or not this increased their risk of asthma or late onset wheeze. So I believe the exposure they were looking at was when children were like 2 or 3 months old. Various samplings of the concentration of dust mite allergen present in the beds of these children, and then looking later when they were, I believe, around 2 or 3 years of age about wheeze, and then beyond that, the development of asthma. And they also looked at endotoxin levels and noted that endotoxin exposure was associated with a decreased risk of ATP, although it still had some increased risk of wheeze. And again, you can also posit that endotoxin may be stimulating a different part of your immune system, which could give you more of a protective effect against allergic disease. We'll talk about that in a little bit more detail. This is another slide that may not be in your slides, but again, the important thing that we're looking at here is the amount of dust mite allergen present in a child's bed in micrograms per gram. They made a point that very low levels of dust mite allergen were associated with a small amount who reported asthma compared to the total amount of people who had that level of dust mite present, versus those who had very high concentrations of dust mite allergen present. They had quite a few more reporting asthma, because that group was a lot smaller, but the increase between, having a little technical difficulties here. The increase from the allergen being present in a very low level of less than 0.05 micrograms per gram to those who had greater than 10 micrograms per gram, there was a 3-fold increase in the amount of children in those groups that had asthma present at a school age when they looked at that over time. And again, this was looking at levels they were exposed to when they were 2 or 3 months of age. Talking about endotoxin in a little bit more detail and other microbial exposures, we've talked about things like life on the farm or life around animals when you're young and how that impacts allergies and asthma as well. So farm animals increase exposure to endotoxin, as does the practice of drinking raw milk, which is something that's relatively commonplace in farming communities. And of course, endotoxin being present is going to stimulate the immune response via the Th1 pathway more, leading to less chance of stimulating the Th2 cells and leading to allergic disease and inflammation. And again, early exposure to these types of things is important to confer that protective benefit against A to B. So there's been a lot of studies that have looked at this. I just chose a couple to kind of highlight. One study back in 2001 from Lancet looked at the exposure of children to endotoxin at less than a year compared to those that were slightly older children in the 1 to 5-year-old age range. And the exposure to endotoxin was kind of assessed via their exposure to farm animals and consumption of raw milk. They showed that the children who were in this age group of less than a year, it was associated, the more exposure they had to farm animals and raw milk consumption, that was associated with lower frequencies of asthma, allergic rhinitis, and ATP in general. More recently, we've had studies that have said, not just living on a farm, but exposure to dogs and other farm animals in the first year of life reduces the risk of asthma in children going forward as far as 6 years of age. And then a study from Jackie kind of looked at the immune response in a little bit more detail with regards to farm animal and farm milk exposure, showing that in their group of children studied, those who had a decent amount of farm milk exposure actually had increased level of Tregs that were developing and responding when stimulated with LPS. So their suggestion here is that endotoxin exposure from being on a farm or consuming farm milk may induce more of a regulatory phenotype. So that may have something to do with developing tolerance rather than promoting allergies with regards to endotoxin exposure and its development of increased levels of Tregs. Another thing that you need to, again, changes in the microbiome that may give you more immune profile and perhaps increase your risk of allergic disease, antibiotic use. There's been a lot of studies on this and some conflicting results, but there do seem to be some studies that confirm or strongly suggest that there's increased risk of asthma with early antibiotic use, whether that's prenatally or in infancy. We'll discuss both. So we talked about this a little bit, but increased antibiotic use seems to paralyze the rise in allergy and asthma, and again, this may be due to altering the microbiome in the gut. And we'll talk about this in a little bit more detail with a few studies that I've highlighted here. So this study in the Journal of Pediatrics from 2012 was looking at maternal antibiotic use, and they had a birth cohort that was selected for their increased risk of asthma, but then they also had an unselected national birth cohort and subgroup that was using antibiotics for reasons other than respiratory infection. And across all those groups, they noted an increased risk of asthma in the children that were born to these women in association with their maternal antibiotic use. And then looking at antibiotic use in infancy, there's been a few studies looking at that as well. One UK birth cohort that had a large amount of children in it showed that if you had some antibiotic exposure prior to 1 year of age, this was dose related, so more numbers of antibiotic courses you had in the first year of life, the higher your risk of development of asthma and other diseases, although asthma is usually the one that's shown the strongest correlation. Likewise, in this Jackie study in 2009, they confirmed that association, particularly between asthma at 6 and 7 years of age with antibiotic use in the first year of life.
That's antibiotic, not the inflammation or infection.
Say that again?
How can you tell that this is...
Right, so there's various studies that have tried to control for that and not, and some of them have said, we can't really conclude that it's not just being exposed to viral infection that has led to this increased wheeze and increased asthma, but some studies have tried to control for that, the amount of, because some of the antibiotic use is not for a viral infection or respiratory infection, so they're trying to control for the fact that, some studies are saying we still see an association even though we've controlled for the fact that they didn't have a high amount of respiratory virus or respiratory infection in the first year of life. So it's really the antibiotic then and not the amount of respiratory infection that's leading to this.
Your question, David, is a lot of these antibiotics are used inappropriately for viral infection.
Maybe
and
they're
that's
used
the
for
stimulus.
something. It's not that you just give antibiotics to people without any reason.
Right.
Not in Israel.
No, but I think the point is that it's a spurious relationship. It's sort of like the issue with acetaminophen, but that's another subject.
Right. I didn't touch on that one, but that's another association. So, some of these studies were trying to argue as well that the association may not hold in later childhood and adulthood, but at least with regards to wheeze in childhood or asthma symptoms at a young age, 6 to 7 years, they do seem to see an association. Again, that could be in a lot of these studies that haven't controlled for it, just the fact that these kids have had a lot of viral illness or RSV, and then that's why they're having more of the kind of transient wheeze.
And all antibiotics have the same effect?
Say that again?
All antibiotics have the same effect? And you
That's a good
separate
question.
with different antibiotics?
I don't know that they looked at a specific class of antibiotic versus another. I mean, they talk about antibiotic use in general, but they don't usually break it down into increased risk with penicillins versus cephalosporins or macrolides or whatnot. But this is just a little table from that later one that was from 2009 in Jackie that was looking at antibiotic use in the first year of life and the risk of these other diseases. And they seem to feel that when they adjusted for things like breastfeeding, amount of siblings, smoking, etc., I don't know that they really were able to adjust for the amount of viral infection in this particular study. But when they adjusted for those other factors, they still saw a significant amount of increase in current wheeze and severe wheeze, and when you had antibiotic use in the first year of life, looking at, again, this phenomenon in these 6 to 7 year olds. So these studies, I agree, are not perfect in terms of being able to control for all of those factors, but they're just mentioning that there seems to be an association. And I think you can argue that in a bunch of ways. You could say, yes, the antibiotics clearly affect the microbiome, we're not controlling for the type of infection, it's hard to say how that may be leading to asthma or allergic disease in the future as well. Another thing that has risen in the last several decades is the amount of obesity, at least in our country and other Western countries across the globe. And so this actually can impact asthma as well, maybe not in a allergic manner, but increasing obesity definitely has contributed to the increase in asthma prevalence, I would say. There's a meta-analysis from 2015. This was looking at children and childhood rates of asthma in obese and overweight children, and as you might imagine, they found an increased odds ratio of childhood asthma in those who were overweight and obese compared to normal weight and underweight children, and that was looking at a variety of different studies. Vitamin D, we talked about this.
But before you skip over that, what do they suggest is the mechanism?
That's a good point. I actually am not too sure about the mechanistic details, but I think some of this obviously has to do with increased body mass and less activity leading to less expansion of the lungs and having more of a effect. Yeah, I mean the sedentary lifestyle and the extra weight being a factor rather than increased allergic sensitization. We talked about some of the studies earlier that looked at increased dust mite sensitization leading to increased asthma. It's not the same mode of conferring asthma. In this group of people, I don't know about mechanistic studies though in terms of looking at do they have increased rates of Th2 activation or allergic sensitization as well as obesity. I didn't look at a study that went into detail on that.
I know some authors have speculated there are leptin receptors on EOs that it may exacerbate. In other words, you have to have some predisposing factor, but it exacerbates it through that. But nobody really knows.
So moving on to vitamin D deficiency, this is an area that's been looked at in quite a bit of detail. And again, we talked about how more sedentary lifestyle these days leads to less time outdoors. Also, dietary changes lead to less vitamin D exposure in general for people. And so quite a few people, especially in our part of the world, are vitamin D deficient. Talked about this basically, but there have been associations made between increased rates of allergic sensitization and low vitamin D levels, and that how it impacts various types of allergic disease. So asthma is an association that's been seen with low vitamin D in quite a few various studies. One published in JACI in 2010 was saying that mild to moderate persistent asthma was associated highly with vitamin D deficiency, and there was also higher odds of severe exacerbation of your asthma with the lower rates of vitamin D levels. Some studies have seemed to say levels less than 30 or so is when your risk of asthma and asthma exacerbations is higher, and that as it increases beyond there, they don't see as much of an association. Another study from 2014 kind of confirmed that having very low vitamin D levels was also a strong correlate for asthma and increased wheezing, as well as allergic rhinitis. Although I think the association with asthma is the one that's been published and studied the most. But interestingly, I wasn't really aware of this, but there have been studies looking at vitamin D deficiency and food allergies as well, particularly peanut allergy, noting that areas that are further away from the equator, so some of these studies I believe were in Australia, had much higher rates of peanut allergy, and again, it's an association, not sure that that's the sole reason why there's less or more peanut allergy the farther you get away from the equator, but certainly they made the association that low vitamin D levels due to that could be contributing to this increased risk of food allergies. Another study in 2013 kind of confirmed that babies who had low vitamin D were more likely to have egg or peanut sensitization and more likely to have other allergic disorders in addition compared to infants who had normal vitamin D levels. So again, kind of an association that's been noted, but I don't think they know exactly why that's the case with regards to food allergies.
When they corrected the vitamin D deficiency, what happened to their allergy? Have there been any?
I don't think it commented on that specifically, but it would be interesting to see. I would imagine if this is something where the vital time point is in early infancy in terms of what your vitamin D level is, maybe if you corrected within a certain time point early on in infancy, your risk would go down, or your sensitization may not lead to a real clinical allergy in terms of food allergies. But I don't know that that's
But it's interesting, this is, before we jump over that, this is an area, a lot of these things we can't do anything about, but this one, I wonder what people in the community do. Do you measure your vitamin D levels in asthmatics? Do you make sure the level's over 30? I do it, when we have a lecture like this, I remember to do it for a while and then I forget to do it. I usually try and get people over 50, and over 30 rather.
All the difficult to control asthmatics, although I don't know how often you usually find it's low, but a lot of people have a low vitamin D anyway.
The guy at the Brigham, I think, thinks the whole epidemic of asthma increase started when we stopped giving babies cod liver oil. Not joking, that's what he actually says, and that change, that was a great source of vitamin D, and it was sort of universal to do that, like up till the 1940s or so. Stuff tasted awful. I remember getting it as a kid. Nick, you probably pioneered this.
I sure do. Do you have allergies?
Like you're saying, from what these studies have inferred, at least with adult asthma, is that the risk of severe exacerbations is higher if you have lower levels, and so certainly in that population, I think there may be some utility to measuring levels, or at least maybe recommending that they have high amount of vitamin D supplementation, even if you didn't check a level. But in terms of what this does with infancy and food allergy risk, I don't think there's really a good way or study that's been done to look at how correcting levels in infancy may impact the disease down the road. But I think, as you said, there's probably some utility to doing this for severe asthmatics, given that we see that association between asthma and severe exacerbation with very low levels.
Yeah, whenever we have these talks for a while, I remember to check alpha-1 antitrypsin and vitamin D, and then I forget and stop doing it.
To have the alpha-1 antitrypsin person back.
Yes. I am setting up, actually, to interrupt you yet again, next year's session. So if you have topics you want to hear, let me know.
When we were at Claudia for the Fellows Conference, Class Mills was pontificating about the origins of asthma.
I was thinking of inviting him. He's
He
such a
blamed
character.
TV,
Huh?
screens, TV. That kids would just zone out and look at it, not take big deep breaths, and not expand their lungs. And just sit in front of that screen all the time. That's what he blamed.
Yeah,
There's a microbiome person, he's like, nah, it's not it, screens.
Yeah, he thinks running around and being active.
Yeah, it's what prevents asthma.
Well, certainly any one of these topics could be explored in much more detail.
He has very strong opinions on immunization, too. That a lot of the immunizations we give people are unnecessary and not useful.
Well, anyway, I skimmed over a lot of these topics, but I think either of you could do a whole session on one of these in more detail and talk about vitamin D deficiency in asthma, or one of the other factors I mentioned, the South research study. Talks about this, the peanut allergies and food allergies with vitamin D deficiency. So that kind of segues into the rise in food allergy. We talked about mostly asthma and allergic rhinitis and how the very discussed like vitamin D levels or increased indoor allergen exposure have shown associations with increased allergic rhinitis or increased asthma. So the rise in food allergy obviously has
Mike wants you to talk louder.
okay. The rise in food allergy obviously has also increased more recently over the last several years, and some of this is due to some of the factors that we already touched on, like there's suggestions that altering the microbiome puts you at increased risk for food allergies, although honestly most of the studies looking at like the gut microbiome or the lung microbiome seem to note higher rates of allergies or asthma rather than increased food allergies. That's been shown to be a strong correlation at least, but there are some studies that have shown altering the microbiome seems to make a difference with regards to sensitization to foods. So the prevalence of peanut allergy particularly seems to be highly increased in the last 10, 20 years. This particular statistic said in the last 10, 15 years or so, the rates have increased, really doubled from 1.4 to 3% in some parts of the world. And again, there's a bunch of different reasons for this, but one of the things that's been pursued as a hot topic for increasing food allergies is lack of diversity in gut And then obviously the different guidelines that have taken place in the last 50 years or so with regards to recommending delaying introduction of allergenic foods, and now going back and saying actually that's probably not the best idea, it has definitely impacted the amount of food allergies that are present as well. So these are just a few studies that have looked at the gut microbiome in more detail. One study, the one in 2010 here, just looked at the gut bacteria in a group of children in Europe and Italy particularly, compared that to gut bacteria in a group of children in a rural village in Africa. And those in the area in Africa were kind of selected because they had surprisingly, or not surprisingly, but very low rates of allergic disease, ATP, autoimmune disease. And so they were kind of comparing and contrasting to see, what's present in one population versus the other, and obviously found very different compositions of the gut microbiome. And again, this is just something suggesting, okay, there are higher rates of allergies and asthma in these European children versus these children in Africa. What are we seeing with regards to the gut bacteria? So there wasn't necessarily a specific gut bacteria that was noted from this study to be implicated in allergies and asthma, et cetera, but they were just kind of making a point that there's an association here between less allergies and asthma and a more diverse microbiome versus something that's a little bit more narrow. In the study in 2014 here, this was a study that was done in mice particularly, and they found that Clostridia-containing mice seemed to confer protection against the development of, I believe, peanut sensitization is what they were looking at in these mice. So again, there have been studies that have suggested perhaps having a certain probiotic or a certain bacteria in your microbiome may lower or increase your risk of food allergies, but I don't think a lot of that has held true, at least for people. This was one study that did seem to see an effect in mice. And they actually found that the Clostridia, the ones that had Clostridia, seemed to be stimulating their innate lymphoid cells, and that was perhaps the reason why they were having tolerance to this, to foods. I believe peanut was what they were looking at in that particular study. And again, I don't think this has been replicated or looked at in humans, but just kind of an example of how they are looking at what specific bacteria in the gut may or may not confer protection against allergic disease, including food allergy, and how that's important in people as well, obviously. So we talked about delaying introduction of allergenic foods. You guys, I'm sure, have all recalled this, as this is something that's happened more recently, but practice guidelines from 2000 had recommended excluding allergenic foods from diets of at-risk children until they were a little older in terms of introducing those foods. There's also been recommendations in the past about excluding foods in pregnancy and breastfeeding. And basically, at this point, through various different studies, we found that there's not a lot of good evidence to support that. So a study published in Allergy in 2014 was a systematic review of many, many studies, at least a third of which they found to be good studies. And they found, from going over these studies, there was really no good evidence to restrict a diet of mothers in pregnancy and breastfeeding, and no significant evidence that delaying introduction of solid foods beyond 4 months of age was protective. They did mention that in certain high-risk groups, not delaying, but restricting the use of cow's milk in infants who are more at risk for cow's milk allergy may be beneficial, but other than that, there was no good evidence shown to restrict certain foods in terms of introduction of complementary foods and solids for infants.
How did that get to be the guideline for those of you who are pediatricians? How in 2000 did this Gus body, I presume, or panel decide that it should be avoided?
Well, I think because they were seeing a rise in some food allergy, not as much as there is now. And I think that I just remember people always talking about how they wanted to wait for the immune system to grow up to not recognize, like these allergenic foods. I mean, I think it was actually from the British pediatric guidelines first. It was like in 1998 or 1999, and then the U.S. adopted it like a couple years later. And then it was like 2006 or 2008 is when the AAP said, okay, you know what, we may not be right, so now we're going to they took it away, but the thing is that the pediatricians, they haven't really made a big change. Even now, it's the families that come in to get their kids peanut tested, like little babies, it's the people who have an older sibling that have peanut allergies. It's not the pediatrician sending us.
Right, it's
They
because-
haven't gotten the
It's
information
because
yet.
the parents know about it.
Right,
The
and
parents
are,
know about the LEAP study more than the pediatrician.
yeah, or at least they're the ones that are coming into our office saying, I want you to test my baby, and can I feed him peanut now at 5 months of age or 6 months of age?
Yeah, I don't see many kids, but it seems to me that consider these are like the biggest studies in our specialty in decades. First front page of the New York Times. The response of physicians has been very lackluster. I mean, like one day it was on the front page, and the next day it was forgotten.
Yeah.
I gave a talk for the Peds Practicum, which is kind of the update for the pediatricians in the area. So everybody I'll come to Seattle Children's, and I presented this data. There was a lot of fear when it came right down to
A lot of fear.
A fear, yeah. The pediatricians, some of them straight up told me, I wouldn't recommend this to our families.
Right.
I'm afraid that they would feed like whole bits of food, like especially the poor Hispanic families. They're afraid that they were going to just feed them whole bits of food directly to them. They would have choking problems and all sorts of other things.
And I think
So-
that, I don't know, but that may have motivated some of this. Like, it can't be a problem if you don't give it. You know what I mean? Which is partially true, but not realizing that you could
Well-
create tolerance.
And I do remember when I was pregnant with my kids, I mean, nuts were off the table because it was a choking food. It wasn't an allergy food, it was a choking food. But you can give them peanut butter.
Right.
So kids in Israel don't choke on Bamba,
Just
right?
because we never follow guidelines.
I've never eaten this stuff. Do you suck on it, or as opposed to eat it as a whole nut?
I think
I
I
mean,
bought some.
I don't know. I've had
It's like
a couple.
it's
I've
like
had
a
a couple.
Yeah.
It's like a Cheeto, but it kind of
Really
dissolves
good. I've
away
had a
once
couple
they get their
11
saliva on
month
it.
So
olds
you
that takes
can't
down
choke
25
on it.
of them.
It kind of dissolves.
We just eliminate all the kids with peanut allergy at 3 months of age, and then we don't have the problem.
Send them to Seattle.
But yeah, no, I agree that's it's a problem that does not
Into zero.
pediatricians for my kids still gives out handouts that are like, no egg until 1 year of age. I'm like, really? That's so we've had discussions about
Yeah, I mean, it seems so disappointing. I mean,
right.
they've spent 5-6 years now with very careful investigation of this issue, and it's, at least in the U.S., it's sort of just, or all I can say is in the Northwest, it seems to be ignored.
I think more education at the pediatrician level then may be beneficial going forward. I did touch again on the studies that we're all referring to. So 2008 was when the publication came out that was looking at the incidence of peanut allergy amongst Jewish children in the UK versus Jewish children in Israel, and this is where the whole idea of Bamba being protective came from, but looking at how there was much lower rates of peanut allergy in those living in Israel versus the UK at tenfold lower level, and so this was kind of where the idea was confirmed, or at least introduced again, that perhaps earlier introduction of allergenic foods could be protected. And this was followed up by a LEAP study and ongoing studies looking at early introduction and kind of confirming, yes, even in children who are at risk and have some slight level of sensitization, giving peanut early will lead to less clinical allergy down the road. So, as you mentioned, very important studies, and I think increased emphasis on this type of thing with pediatricians and hopefully help going forward in terms of getting children to eat more highly allergenic foods earlier in life. Perhaps we'll see a reversal of this trend in the next 10 years or so, but at this point I think it's kind of slow to catch on, as you all said. So I am I think ending earlier than I expected, but this is just kind of a summary of what we touched on. And again, as I said, this is a very vast topic, so any of these individual factors that we discussed could be discussed in more detail. But allergic disease, as I mentioned, from the history of it, is relatively new in terms of it's only been around for about 100, 150 years. Various factors have led to the increase in allergic disease, and this includes things like advances in hygiene, as we mentioned, things like immunizations and antibiotics, and obviously eradication of other infections and parasites and worms, things that had stimulated the Th2 response in the past. The large transition from living in more rural settings to living in more urban settings obviously is contributing as well, in terms of people in urban settings are having lack of exposure to things like farm animals and endotoxin, as we touched on. I didn't really get into this, but obviously in urban settings you have higher degrees of pollution. You can also discuss kind of gene-environment interactions and epigenetics in terms of increased risk of allergies and asthma and how certain pollutants seem to be altering our immune system, leading to more allergies and asthma. I didn't touch on that in great detail, but that's another factor that's contributing to increased allergies and asthma. And then increased levels of allergens, spending more time indoors, being in environments where we have higher humidity in homes and we're having more dust mite and mold levels that people are being exposed to compared to what was going on 50 or 100 years ago. And then obviously lifestyle changes, at least in Western countries where we're talking about a more sedentary lifestyle focused around more screen time, changes in the diet over time, and more processed foods and things that are contributing to obesity and probably a less diverse gut microbiota. All of those things together are contributing to the increase in allergic disease. And it's hard to piece out and say, which thing is contributing the most and which should we focus on. I think it's important, as you mentioned, that there aren't a lot of things that we can necessarily do to impact this, but if there is something like perhaps checking vitamin D levels in the severe asthmatic, where you may be able to make a difference by doing an intervention like that, that's good to know about and pay attention to. But a lot of these things are kind of retrospectively looking back and saying, okay, were you exposed to animals and how soon did you introduce this food and that kind of thing. I think the food allergy guidelines obviously are something we can also make an impact on going forward, as we discussed, especially if we're able to educate pediatricians in the community and make a bigger impact there. That's another thing where you could potentially prevent a rise in allergic disease. Some of these things can't necessarily do a whole lot about. I think antibiotic use, perhaps, trying to educate and reduce the use of antibiotics unnecessarily is important for a whole host of reasons, not the least of which is that it may contribute to the rise in allergies and allergic disease. Again, that one is a little bit more muddy, not as clear-cut as some of these others, but there are certainly various ways we can try and impact our community by lowering the risk of allergic disease by limiting some of these practices. And then we touched about the hygiene hypothesis and the microbiome, and I think there's going to be a lot of study, even more going forward in the future, that tries to pinpoint which specific gut microbes and microbes in the lung, perhaps, that are contributing to or giving a protective effect with regards to allergies and asthma, and how this could be altered, perhaps. There have been many studies looking at the use of probiotics in pregnancy, and whether or not that does anything with regards to food allergy sensitization. But I think that will be continue to be a very hot topic area in the future in terms of research and things we may be able to do to influence allergic disease. Yes?
I remember reading that Spain has the highest use of antibiotics, and maybe some of it's not appropriate. Do you see any evidence that Spain has a higher incidence of allergic diseases, or any other country for that matter?
I didn't see that for Spain specifically. I mean, a lot of these studies kind of lump together different countries in Europe and the U.S. and talk about Western countries versus developing countries. I did see some studies that talked about increasing amounts of asthma in countries even where dust mite's not an important allergen, for instance. So there's certain theories where they're saying, this doesn't hold true in all countries, but I didn't see anything about Spain specifically with regards to antibiotic use.
Sometimes I think about this in a global way, since we're allergy and infectious disease. On balance, is the world better because of hygiene and antibiotics? The more people live and survive because of those changes versus inducing allergy and autoimmune disease as a consequence of that? I would say on balance, yes. I mean, clearly, like we didn't eradicate, but tuberculosis was the scourge of people at the turn of the century, and just by changing living practices, people not crowding together, that was more effective in reducing tuberculosis than anything else that was done. So this is sort of the price we pay for advances in antibiotics and advances in lifestyle. The other thing I always wondered about is atopic disease very low in Africa because the immune system, the Th2 immune system, is doing what it's intended to do. It's fighting multicellular parasites, and it doesn't have time to deal with irrelevant allergens. That's the way I look at it.
What
Right?
pollen do they have? I mean, what pollen do they do? I mean, if you go out to, there was a site about the rural. I mean, what was the pollen count
Right.
there? I mean, maybe, is it also any of this linked to our pollen exposure? I mean, and also I think sometime I was reading, I don't know whether global warming is changing what's going on with our pollen.
It definitely is. I mean, Jeff DeMaine talks about birch tree pollen counts up in Alaska is dramatically changing, coming higher and much earlier in the year. So, I mean, that's clearly another thing happening right now.
When you talk about the communities in rural Africa, I think there's a bunch of different factors going on there, one of which you touched on, the amount of parasitic worm infection and whatnot that they're exposed to, as well as other infections, certainly is probably contributing, but the lifestyle there is obviously very different as well in regards to obesity or activity level and risk of asthma, various types of things like delivery, obviously, well, a C-section and things like that being performed in rural countries and parts of the world. So there's a bunch of different factors that we touched on that are probably quite different in that community. But I think even controlling for some of those things, some of the studies have said there are certain parts of Africa and other parts of the world where there's populations that just don't seem to get allergies, even when you control for those factors amongst different populations. So I think there may be some genetic component as well.
I think it also depends on the environment. I don't know if there are a lot of, I'm sure there are studies about it. When I was in Israel, I used to volunteer in a refugee clinic, and we had a lot of people coming from Africa. And one of the things that I was very impressed by is the amount of number of cases of allergy. These people never had any allergies before, and 2 months later they come up with asthma and different atopy things. And I didn't pay a lot of attention to that time, but I wonder if they see the same thing in Europe now. So,
I remember the same thing when we had a clinic at Harborview decades ago. This was the time of the Vietnam War, and we had people at the war ended, and we had a large number of immigrants from Southeast Asia. None of them ever gave a history of having an allergic disease over there, and after living in the U.S., and I never knew, still not sure, is that was just something in those cultures you didn't even talk about. If you had those symptoms, they weren't. Having a stuffy nose or sneezing was not anything anybody thought was a disease, and they first learned in American society you could report those symptoms, or if they truly acquired it. I've come to think probably they really truly acquired it after they moved to the Western world.
It's usually not subtle. It's pretty bad.
Huh?
Right.
It's usually very bad.
Yeah.
No, they're miserable when they come over. Yeah.
Yeah.
It's
They
fascinating.
all seem to have a very much more brisk response. Like some
Yes.
of them, I kind of know their skin tests are going to be huge, or if they're having allergy shots, they're kind of reactions. You're
Yes.
kind of a bit more on the alert for some reason. I think they have a slight different genetic.
It's interesting. I just came back from an international conference, and there was.
You were in
sorry,
Hong Kong,
I was in Hong Kong, yeah. So I was talking to a allergist, Dr. Singh from India, and one of the docs from Hong Kong. And the Indian doc, he's been practicing for like 20, 30 years, he has never seen peanut allergy. He's never even heard of peanut allergy in India. 1.2 billion people, no peanut allergy. He's one of the big allergies there. Not even a case report description of a native Indian. He says everything is mild. Asthma, he sees it, very mild. Allergic rhinitis, yeah, we see it, very mild. It's nothing big.
Will they do anything like they do in Israel?
No,
Do
I
they
asked them
have
specifically
peanuts?
about that, and there's no specific thing that they introduce. No peanut introduction, nothing. It's just they just kind of, but they don't have anything to avoid. But they just kind of do what they do, round up stuff. But peanut can be, but it's not a typical part of Indian cuisine. I've never had peanut in Indian cuisine, so I don't know. And then the Hong Kong doc is kind of like us 20 years ago. So it's like, nothing to like, yeah, kind of, but nothing too bad. And then for me, it was like, the worst. And so they're starting to see a rise in their food allergy, but not as bad as we have it. So it's very interesting to see how development of the world. And most of the third world docs really, if they saw allergy, is usually what we saw 80, 90 years ago, egg, milk, and that they would grow out of it.
Well, that would certainly support the hygiene hypothesis
Yeah.
in India.
But not the antibiotic, because they use plenty of antibiotic in India. microbiome, I'm sure it's disrupted. They have plenty of antibiotic-resistant everything bugs over there. So I don't know. I think the TH2 simulation hypothesis probably is like the best. Just parasitic.
Well, I guess you get young guys who are going to have a lot of business. You know, specialty's growing. Maybe not good for mankind, but it's good for allergists.
That's probably, as you say, you know, the hygiene hypothesis, the microbiome, and all that plays into it. But I think it's a mixture of a bunch of different things. Perhaps things that stimulate or don't stimulate TH2 response. I think obviously that makes sense. That's probably a big factor in terms of what's contributing to allergies or not in different parts of the world. But I think, you know, here in the US we have kind of this perfect storm of all these different factors going on. Whereas, you know, in another part of the world maybe they're overusing antibiotics, but they're still being exposed to plenty of, you know, parasitic infections and other infections, so that doesn't quite tip you over to this unbalanced state enough. But I think it's kind of this interplay of all these different factors, and over time we'll see which one is the most important, the biggest factor. But right now, I think still anyone's guess what's driving it the most.
All right, so we'll see you next Tuesday evening up at the faculty club. The meal and alcohol is free. I can't give you free parking though.
Thanks for sending me a research. I can't remember where.
I'll send a map out later where it is. If you know the university campus, it's across from the hub.
Is it just where the hub is?
Huh?
It's across from the
It's
hub.
across the street from the hub.
Looks like you got some.
It's on campus.
Still getting
It's on campus.
cycling probably. Onward.
I should start my enthusiasm
Yeah, I was going to ask you something before.
Hey, how's it going? Good. That's good. Dorvin Friday. Memorial Day weekend.
I have to check if I'm in that office. If I am and I'm free, I'll come by.
Yeah,
Okay.
just wanted to extend the opportunity.
Yeah, I got your business card yesterday and I got too busy to call you. I know you went and talked to Yashi, right?
I did,
Yeah, she brought it to my attention.
Fantastic.
LinkedIn so he could see his last name.
The other thing is stuff with portrait will be here.
What?
I know Dr. Ayers said he's not going to be
Yes.
available next week. When we did this biologic talk, there were some questions. And certainly Dr. Forchak, as our U.S. medical lead, would be in a great position to answer some of those questions. You think there may be an opportunity before the final journal club in the evening to have him available to answer some of those questions?
So I don't know what forum is the problem.
Yeah.
We don't have a group. This was the last time we got people together like this.
Yeah, it would be a little difficult. I just thought I'd throw it out there to see if that was something that we could work out. But
You know, we'll be together that evening, but that's not an appropriate forum. That's a dinner and a social function.
absolutely.
So, can't help you there.
Okay, just see. Thank you so much. Appreciate it. We'll see you next week.
All right.
Dr. Altman,
Yeah.
how are ya?
What can I do for you? Like,
We brought the profile of Dr. Rafi from UCLA.
So, he listed off 5 of the different CME lectures that he could do.
One is the immunodeficiency. That's what obviously Dr. Rydell did last year. If you wanted to fill that space, if you do like his profile.
well, let me take this.
Yeah. Let me know. He had mentioned that this one
I
there's
probably wouldn't pick that. I know you want that one
immunodeficiency,
pick. But,
battling diseases.
Somebody would do one next year on immunodeficiencies, right?
well, I mean, we have in-house people. I'll probably
Right.
have Troy do something
Oh,
again.
yeah.
So
That'd be great too.
I'd probably pick a different topic here.
Well, we were also thinking when you guys brought up Alpha 1, you know, we have an Alpha 1 division within Baxalta. So, I mean, we'd be happy to help with that.